everyone. Just going to give it a minute to let folks join. All right, I'll get started. Good afternoon. Welcome to today's Research America Alliance discussion. I'm Jacqueline Lagoy, and I'd like to thank you for joining in on Zoom today and for your partnership in the Research America Alliance. Joining me in moderating this discussion is my colleague, Ellie Dahoney. So I'd like to start off with a little housekeeping. If your organization is not a member of the Research America Alliance, I hope you'll reach out to Kristen Furlong, our Director of Membership and Development, whose email is in the chat. She'll be able to give you more information about our alliance. So great to see everyone joining. We ask that you stay on mute for now, but please feel free to turn on your camera. So to the good part, it's a privilege to introduce our guest speaker today, Dr. Christine Peat. Christine is the director of the National Center of Excellence for Eating Disorders and president of the Eating Disorders Coalition for Research, Policy, and Action. Thank you so much for joining us, Christine. We have so many questions for you, so let's jump right in. So Christine, to start us off, would you mind briefly describing the range of disorders under the quote unquote eating disorder umbrella?
Yeah, happy to. And thank you so much for having me here this afternoon, or maybe this morning, depending on where folks are joining from. But when we talk about eating disorders, we're talking about a group of different psychiatric conditions that broad brushstrokes describe people who have difficulties in their relationship with food or with their body. So for some people, that might mean overeating or eating too much. For some people, that's eating too little. For some people, it's problematic relations with exercise or other sorts of things that are kind of focused on losing weight. But really, it describes a group of conditions where folks are experiencing real difficulty in either the relationship with food or with their body. But this isn't just sort of like a one-off thing that happens a few days a week here or there. We're talking about really kind of pervasive conditions that affect somebody's entire life and cause a really significant amount of distress or impairment in their day-to-day functioning.
Great, thank you for that. So I'm sure people in the audience are kind of aware of, or they've heard many things of what an eating disorder could be, and the terminology or the definitions can be vague, or it can just vary from person to person. But just wondering, is it difficult to identify an actual eating disorder relative to quote unquote normal range of eating and exercise habits given our society in this country and other countries also really emphasize, or there's so much different messages about what's healthy and with eating and exercise.
Yeah, absolutely. And I think that's part of what makes this entire landscape just so difficult to navigate is that, I think generally speaking, particularly here in the United States, but also in other westernized countries, there's just such misinformation out there about what's healthy, what's not when it comes to your eating habits, your relationship with your body. And it gets really difficult to sift through what's actual fact versus, what you might find on a blog post, for example. So when we talk about eating disorders as conditions, we really think about these again as mental health or psychiatric conditions that have significant distress or impairment associated with them. So this isn't maybe just, for example, being unhappy with your weight and shape. Those are things that are very common as part of eating disorders, but just having that alone doesn't necessarily mean that you have an eating disorder diagnosis. So again, we're kind of thinking about a constellation of different symptoms when it comes to these conditions. And it can be really hard to detect eating disorders because most people with these conditions aren't going to have frank signs or symptoms. In fact, so many people with eating disorders are going to look perfectly healthy. I know that unfortunately there's a stereotype that people with eating disorders have a certain look. I think oftentimes what comes to mind are images of people who are really underweight, people who are really medically compromised. But in reality, that's only a very small percentage of people who struggle with these conditions. So I think it's also important to be thinking about who we aren't typically capturing when we think about these conditions.
So Ellie, did you want to jump in?
I just wanted to, yeah, I think that that really is, Christine, such a big part of this is that it is difficult to understand where eating disorders end and the conversation that's fraught for most of us around eating, or not, I mean, I think in some senses, um, it's also guilt inducing because we're allowed to think about food and think about exercise and so those lines for those that are in the research and clinician community, are those lines pretty solid and firm between when a person, when you're going to say this person actually has an eating disorder and this person does not, they just are thinking about these issues or
It's a great question, and I'm going to give you sort of a typical psychologist answer, which is depends. It really does depend. And strictly speaking, if you're asking about the nosology, the diagnostic classification system, certainly we have that. There's a list of different criteria that you have to meet in order to have what we would call a threshold eating disorder. Right, your symptoms meet the threshold of whatever the nosology is currently, and that will vary depending on whether or not it's anorexia nervosa, bulimia nervosa, binge eating disorder. We can talk about those if there are specific questions about those diagnoses. I think one of the things that makes it really challenging, though, when it comes to eating disorders is a number of things. Number one, there's a lot of what we call diagnostic crossover. So people may start by presenting with something like anorexia nervosa, and over the course of their illness, end up going on to develop bulimia nervosa or binge eating disorder. So it's not as though these are sort of clean, discrete categories. Somebody may struggle with a variety of eating disorder diagnoses over the course of their lifetime. So that's one challenge. I think the other thing oftentimes that I get questions about is sort of this difference between disordered eating and having an eating disorder, which Ellie may be part of what you were bringing up. And it can be really hard to sort that out. I think that many people may struggle with disordered eating thoughts or behaviors. So having your relationship with food or your body take up more mental real estate than you want it to. But that doesn't necessarily always rise to those threshold criteria of having, a clinical eating disorder. And oftentimes that takes really careful assessment with somebody who specializes in these conditions to try and figure out, what are the through lines, between disordered eating and a full eating disorder diagnosis. What I want to make very clear, however, is that you don't have to meet every single diagnostic criterion that's laid out in the DSM in order to ask for help. In fact, what we really encourage folks to do is that early on in their symptom trajectory, to reach out to either a trusted family member or friend or somebody on your medical team so that you don't end up needing maybe to go through a full course of treatment. If we can catch these illnesses early, maybe we prevent folks from being ill for years and years at a time. So despite the fact that there's some messiness when it comes to diagnosis, classification, what I'd like for folks to hear is that it's never too early or too late to reach out for help.
Jacqueline, if you don't mind, one more question, and I think this one is fraught, but that's what we're here for, right? Hard questions. So let's say I go to the doctor and the doctor says, you're overweight or underweight. And I come back and I say, I don't care. I choose to be overweight or underweight. And in fact, body positivity is much better than body shaming. And I'm feeling like, to hell with you. I'm overweight. I'm gonna get more overweight. And so what? Is that a separate set of issues than eating disorders, or is that in the same, is that an eating disorder topic?
It's a great question, and thank you for bringing that up. I think there's two important things to think about there, and I'll start with maybe the easier one, although it's certainly not an easy topic. I think that there is a certain degree of autonomy that people have when it comes to their medical conditions or their mental health conditions, right? Just because your doctor has diagnosed you with high blood pressure doesn't mean you have to take the medication that's been prescribed to you. In the same way, if your doctor diagnoses you with an eating disorder, it is still your choice as to whether or not you get treatment. Of course, as somebody who specializes in these conditions, I would hope that folks would be willing to have that conversation with their doctors, but we also want to be respectful of those choices. So that's one part of it. I think part of the question that you asked. I think the other part has to do with living at higher weight, higher BMI, those sorts of things. That in particular is not an eating disorder diagnosis. So simply living in a larger body, having an elevated BMI, that does not constitute an eating disorder. There is sometimes some overlap with eating disorders for folks that live in larger bodies. And I'd like to call to mind two specific things. I think that oftentimes what we think about when we think about folks that may have overweight or obesity, we think, oh, well, they must have an eating disorder because their body is too large. That's just not the case. I think it's outdated thinking, and it's something that can keep kind of folks feeling shameful almost about their bodies. The other thing that happens is that there's oftentimes an assumption that folks that live in larger bodies, if they do have an eating disorder, it must be binge eating disorder. That must be the only thing that they're struggling with. When in reality, there are many people who have an elevated BMI who may actually be struggling with what we call atypical anorexia nervosa. Atypical anorexia nervosa is a diagnosis that describes people who have all the same thought patterns, all the same behaviors as we see in sort of classic or more typical anorexia nervosa. So not eating very much, being really focused on losing weight, being afraid of regaining weight, all of those apply to these people with atypical anorexia nervosa. It's just that these folks never actually become medically underweight. In fact, their BMI may be in the overweight range, it may be in the obese range. But in reality, we're talking about the exact same symptom picture, the exact same kind of behavioral picture. It's just that they never become sort of medically compromised when it comes to being underweight, if that
So
makes
it's the
sense.
trauma of it. It's actually that it's disrupting their day-to-day lives, or
It's that, and it's also pretty significant physical sequelae, right? So these are patients that will be malnourished. You can be malnourished at any particular weight. What I always tell people is there's no such thing as a good food or a bad food. You can be malnourished if all you're eating is Twinkies. You can be malnourished if all you're eating is kale. The idea is that there has to be some degree of variety
yeah.
here, right? So when we talk about atypical anorexia nervosa, we actually are seeing a lot of the same medical complications that we see in patients with underweight. So we're talking about difficulty with their GI system. Sometimes there are cardiac problems. There might be other kind of neurological problems that are happening as a result of either really rapid weight loss, even if your BMI is high, or as a result of being malnourished. So it does get a little bit tricky in terms of trying to tease these things apart. But I'm hoping that what folks are hearing is with the take-home message that, there is no particular look to having an eating disorder, and that somebody can struggle in this relationship with food or with body in a number of different ways.
Thank you, Christine. So this is conversation great so far, but it's having me think about the upcoming. I know that you work at UNC Chapel Hill on a college campus or nearby the college campus. So I know that eating disorders can show up with individuals often in college years or adolescence. But thinking about the upcoming holiday months, Halloween, Thanksgiving, Christmas, Hanukkah, I know it can be a difficult time for those who struggle with disordered eating or have unhealthy relationships with food. What do you and I don't know if you say the acronym NCEED, what do you all recommend for those affected, and how can others best support loved ones in a healthy way?
It's a great question, and it's also sort of hard to believe that we're already rolling into the winter holidays. But I think that when it comes to navigating that particular season, it's important to really kind of take stock of where you're at. So if you know that you're early on in your treatment journey, how are you setting up appropriate boundaries with family members or friends who might say things that are problematic, even if they don't mean to, even if it's not the intention to be hurtful, right? Or if you're somebody who's further along in your recovery, are you working with your therapist to try and anticipate some of these challenges that might come up when you go home? One of the things we hear oftentimes from our college students is that they may not go home for an extended period of time. Maybe they do for fall break, maybe it's the winter break, and it may have been several weeks or months since family members or friends have seen them. And if there have been changes to their body, our culture is one that sort of promotes this idea that it's okay to comment on that or to talk about it in some way. And when you're really early in trying to sort of figure out eating disorder recovery, those kinds of comments can be really jarring. So, Jacqueline, one of the things I liked about your question is this angle of what can I do if I'm a loved one or a friend of somebody who I know is struggling. I think first and foremost, low hanging fruit. don't make appearance-based comments. And this would be true not just in the holiday season, but generally speaking. I've been in this field for a long time, so I feel like I sort of have a luxury of having a little bit of a bubble, but we just don't talk about appearance when we're in kind of these eating disorder spaces. Because even if you're meaning it to be a positive thing or a compliment, it reinforces the idea that your appearance is what's important about you, or it's one of the more interesting things about you, when in actuality, most of the time, it's one of the least interesting things about you, right? I think the other thing too is to really focus on the relationship that you have with people, the good and the positive changes that have come up. If you're coming home from college, what have you loved about college so far? What's been fun for you? Focusing on the things that really strengthen your connection with family and friends versus things that are maybe a little bit more superficial, like diet and exercise. So, Jacqueline, I don't know if that kind of gets to the question that you have, but that's kind of what comes to mind for me.
Definitely.
I have a
Yes.
quick question, if you don't mind. So, I'm a Generation Xer. Maybe eating disorders weren't really discussed as openly as it is now. And I didn't live on my iPhone. So that also was not an issue. But the college experience, I think, I experienced, because I've always been a small, thin person, where if I would lose 2 pounds, someone would be like, "Oh, are you anorexic?" So there's a lot of this, like, thinking that someone's anorexic when they actually are pretty healthy for their height and built and all that. But that was a big issue in the 90s when I was like going through school and stuff, was that you'd get labeled anorexic just because you were like a thinner or smaller bone person. So what do you say to that when there's a lot of misdiagnosis, or just I'd say skinny shaming people that are actually just naturally skinny, and not um so that you are getting that out there, that not everyone has an eating disorder if they're thin. They might just be thin, or like you said, that atypical, like I would never have thought back then if someone was overweight that they'd have an eating disorder. So like, how do you like myth buster all those types of things?
Yeah, it's a great question, and I appreciate you bringing that up. I think that maybe the overarching principle here is to remember that there is no particular look to an eating disorder, and you cannot tell just based on looking at somebody and their physical appearance whether or not they have an eating disorder. There are some folks that have constitutional thinness. There are some folks who have experienced weight loss because of other medical problems, right? So if they're dealing with other chronic health conditions or other sorts of challenges, that may contribute to some weight loss, even if they're already in a small frame. So I think part of the theme here really is challenging the assumptions and the stereotypes that we have in our mind about eating disorders, right? And I think anorexia nervosa is a really good example of that, where most people think about anorexia nervosa as people who are extremely underweight. These are people who aren't eating anything, which is also not true. People with anorexia nervosa do eat, they just eat very little, right? And I think that unfortunately, because of that, if you sort of creep towards that description, there might be a tendency to label, right? In the same way that people who live in larger bodies or people who may have elevated BMIs, there may be assumption that they're not taking care of themselves, or that they don't eat well, or that they're not experiencing any kind of eating disorder symptoms. I think it is true really on both ends of the spectrum that we can't make these assumptions about somebody's health, about their eating disorder status, just by looking at them. And so it's more about, if you're a family member or a friend or a loved one in some way, figuring out if you're seeing behavior changes, if you're seeing changes in mood or in other sorts of tangible ways, right? So if the college context, if you have a friend who stops going to dinner with you every night like they usually do, or you notice that they're not interacting with you in the same way that they typically have, those would be things to clue into, maybe more so than just physical changes.
Yeah, I liked what you had to say about returning home, because that is really important. I mean, so that you're not shaming someone for if their body's changed either way from college, because I could see that as a big issue.
Yeah, absolutely.
Absolutely.
Chris,
Jay, do you mind if I ask or you go ahead, I'll go next.
I was just wondering, Christine, what brought you to this field and specializing in eating disorders?
Yeah, it's a great question. I'm the daughter of a physician and a pharmacist, so I grew up in a sort of heavy medicalized context, for better and for worse. But I was always really interested in human behavior. So that intersection of medicine and human behavior really is sort of where eating disorders lie. And so because of that, I just got really fascinated in eating pathology writ large. And then I fell into the world of research, and then obviously with my clinical training, and it just sort of took off like a house on fire. So it was sort of a combination of professional interests, sort of my family upbringing, those sorts of things, but have been in the field really since, gosh, I guess 2006, which seems hard to say, but yeah, it's been the primary focus of my career.
Terrific.
Yeah.
Looks like Veronica, you want to hop on and ask a question?
Hi, yes, sorry, I am coming back from another meeting, so I can't be on my video. And I was a little bit late, so I'm sorry if this is something that's already been talked about or answered. But when I was in college, I implemented during Eating Disorder Awareness Week, a panel that brought on a therapist, a nutritionist, somebody that experienced an eating disorder, and somebody who knew somebody that experienced an eating disorder. And I felt like that was something that a lot of people, appreciated. They were able to answer or have their questions answered about these things, whether they were experiencing it or, they had a friend or a family member experiencing it. And I was wondering if there's, anything going on in, anything that we could do on college campuses or even in high schools. I personally, that is when I was struggling with an eating disorder. So again, sorry if that's a question that's already been answered. I genuinely really appreciate that we're having this conversation right now, but it's really like, what can we be doing going into schools and actually making sure that this is talked about, considering this tends to be such a taboo, conversation and thing.
Absolutely. Thanks, Veronica, for that question. I think that thankfully there are actually some really robust efforts happening at the K through 12 level, in addition to the post-secondary level when it comes to eating disorder awareness, eating disorder trainings. I'll see if I can put some of this into the chat later, but there's an organization called the National Alliance for Eating Disorders. And they're an organization that does a ton of outreach to college campuses in particular. And they have some really engaging strategies to work with Panhellenic councils, but also just the larger student body. And they've been really spearheading this work for a number of years, in addition to the National Eating Disorders Association, or NEDA, which I'm sure many of you are familiar with. They're actually probably the longest standing nonprofit in the eating disorder space. They have all kinds of toolkits when it comes to, college campuses or educators, those sorts of things. So there really are a wealth of different resources that are available in that particular sort of post-secondary context. For the K through 12 schools, there's also some really robust efforts happening specifically with the National Alliance for Eating Disorders. They've partnered with an organization called Be Real, which is run by a woman named Denise Hamburger. And their whole focus is really on improving, sort of doing some, I guess, primary and secondary prevention work, looking at body image, sort of social emotional learning, all of those basic building blocks that if we can make sure that those are in a firm foundation early on, maybe they help prevent the onset of eating disorders. And so there's some great curricula that are out there that do some of that early work that's age appropriate. There's also an organization called With All, and With All is a great nonprofit organization that's focused on giving parents, caregivers, teachers, coaches the language of what to say if they're interacting with kids in this kind of K through 12 context. So what should coaches say if they're working with teams? What should teachers say? What's language that they should stay away from, for example? So there's a wealth of different resources that are out there that are focused on those areas, because, Veronica, of exactly what you said, it's an age group that's really at risk for the onset of eating pathology in that kind of adolescent childhood development period.
Great, thank you so much.
Terrific. Christine, what and if Tori or somebody who's watching from Research America, if you could put a couple more of those links into the chat, the National Eating Disorders Alliance, I didn't get to that one. That'd be great. Nature versus nurture, or environment versus genetics. What's known, what do we know and what don't we know in terms of eating disorders?
Yeah, it's a thorny issue because the science doesn't move maybe as fast as we would like it to. But I think that one of the things that we have a firm understanding of at this point is that when it comes to eating disorders, it's nature and nurture, it's genes and environment. It is not one over the other. We all live in sort of this toxic society when it comes to body image ideals and relationships with food. So if it was simply an environmental problem, we would all have an eating disorder, right? But the reality is that eating disorders occur in people who have genetic vulnerabilities to these brain-based disorders in combination with environmental factors, their own personal psychology, life experiences that they might have had. So really those two things go hand in hand. In fact, some of the research that's been done here at UNC led by Cindy Bulick, who is the world's foremost expert in the genetics of eating disorders, found, is it 2 years ago or three? I've lost track of time with the pandemic, but she and her team here at UNC were responsible for identifying the first three genetic loci associated with anorexia nervosa. So we're starting to learn more and more about those basic building blocks of who might be vulnerable to eating disorders. She and her team are also spearheading the same sorts of efforts for other eating disorders. So looking at the genetics of binge eating, at the genetics of avoidant restrictive food intake disorder or ARFID, so that we can have a more comprehensive understanding of how genetics might interplay with environment when it comes to vulnerability to these conditions.
Wow. And along those same lines, are there clues in comorbidities, or I think it probably is cause and effect, but I know that there is research around eating disorders and things like OCD or depression. Could you speak to that a little bit?
Yeah, absolutely. I think probably the most common comorbidities that we see when it comes to eating disorders or eating pathology writ large tends to be anxiety, depression, anxiety inclusive of obviously generalized anxiety disorder, but also OCD, panic, those sorts of things. There's also a significant overlap with substance use disorders and with trauma and other related stressor kinds of disorders. So PTSD, that whole gamut. Unfortunately, a number of folks with eating disorders have a history of exposure to traumatic events, whether that was in childhood or in some other sort of part of their development. And so many people find that they may have experienced a traumatic event, or maybe they had depression or anxiety early on in their life, and then they go on to develop an eating disorder. For other folks, it's the other way around. For some people, they actually start with an eating disorder and then go on to develop anxiety or depression or substance use disorders. So there is no sort of one specific journey there, but the overlap or the comorbidity between eating disorders and other psychiatric conditions is very high.
I recall that when I was in college and high school, and this was kind of when we were first talking about this way back, but there was and I think it goes to the, I don't really know much about the avoidant, that you mentioned, a disorder that has the word avoidant in it, but I remember that folks would say, oh, it's a control thing, that it has to do with discipline and control over food. I don't know if that thinking has evolved, or if that speaks to some of the other the comorbid conditions. But if you could start by going back to the disorder you mentioned, avoidant. I'm so sorry, I've forgotten now.
Yes, I know it's a mouthful. I don't expect anybody to memorize it, but it's the acronym that we use is called ARFID, ARFID, and it's avoidant restrictive food intake disorder. And the idea is that ARFID describes a condition where people are not meeting all of their nutritional needs, but it's not like an anorexia nervosa where they want to lose weight in order to be thin or have a certain body image or have a certain number on the scale. People with ARFID are not meeting their nutritional needs because they have difficulty with the sensory characteristics associated with food. These might be people that are afraid of negative consequences of eating. So, for example, they may have had a choking accident in the past or really bad GI upset when they ate. Or these may be people that just fail to prioritize eating. So they have hunger and satiety cues, but they just don't ever get around to prioritizing eating for themselves. And what I want to be clear about here is that this isn't just like I got busy at work and I forgot to eat, or, you know, I have a particular pattern around picky eating. I only eat certain foods. ARFID is really a much more pervasive and persistent pattern. So these are people who have done this for years. They may actually end up being malnourished. Many times these people are relying on nutritional supplements like drinking Boost or Ensure, and it's having really significant negative consequences on their daily lives. So maybe they're not able to function at work in the way that they typically do. Their interpersonal relationships are suffering. ARFID was originally thought to be a diagnosis that was limited more towards childhood or adolescence, but we're really having a much better recognition of the fact that ARFID can occur well into your adulthood, and we're actually diagnosing that quite a bit. When it comes to the other piece of your question around the control component, it is, I think, part of the initial conceptualization that we had about eating disorders, particularly for restrictive eating disorders like anorexia nervosa, for example. But I think that with the more recent research that's come out over the last couple of decades, we've had an appreciation that that is much more complex than maybe we originally thought. So people may engage in eating disorder behaviors for any number of reasons. For some people, it may be the way that their brain is trying to make sense of having been exposed to trauma. For some people, it may be a way to help regulate their emotions. For other people, it may be a way to kind of escape really big or scary emotions or thoughts that they might be having. So instead of it being sort of a disorder that's focused on rigidity or control around food, it may just be reflective of some individuals having just difficulty in general navigating key portions of their life. And they find that their relationship with food is kind of what takes the hit, or their relationship with their body is the thing that takes the hit. So again, I think for some people, it may kind of fit that description of, wanting to control food because they feel like they can't control anything else. But for many, many other people, that symptom picture or that motivation to engage in eating disorder behaviors is going to be very different.
Jacqueline, I promise I'll turn this back over to you. I have one follow-up to that, and that is, this has been eye-opening to me in that I always thought eating disorders, that's something that would be kind of a fear of food or a fear, that would be a different type of disorder. I always associated eating disorders with food and body interaction, whether it's weight or that. So it's really interesting to me. It's a far wider net actually than that. But I see Jeff has a question, so.
Hey, Christine, how are you?
Hey, Jeff.
One of the things I think that is interesting is that as we've discussed, there's limited amounts of individuals who are well trained to provide the care that individuals need for eating disorders. Can you talk a little bit about the range of care that because it seems that it ranges from people who have to be medically stabilized off the bat if their condition is so significant, to being able to help make sort of changes around their eating dynamics. Can you talk a little bit about that?
Absolutely. I'm happy to talk about that continuum of care. Before talking about some of the specifics, though, what I'll lay out is that when it comes to the treatment of an eating disorder, the standard of care is multidisciplinary treatment, such that there is a therapist or a counselor who specializes in eating disorders. There is a dietitian who specializes in eating disorders, a physician that also ideally specializes in eating disorders, and then oftentimes psychiatry or other prescribing providers to help provide medication management for psychotropic medications and to help manage some of the other psychiatric comorbidities that might be there. So with that backdrop, the expectation is that all eating disorder treatment, standard of care, is multidisciplinary. Within that, though, there are a number of different levels of care. So everything from outpatient, where you go to see your therapist and the rest of your treatment team about once a week, whether that's in person or virtual now in the wake of the pandemic, all the way through inpatient hospitalization. And inpatient hospitalization can be on a medical floor because you are so medically compromised that that's where you need to be, or it can be in a psychiatric hospital. There are all kinds of freestanding psychiatric hospitals that exist, and many of them have eating disorder units. So when we think about kind of those two bookends, we're really talking about outpatient and inpatient. In between there's all these other kinds of levels of care. So intensive outpatient treatment might be meeting with your multidisciplinary team 3 times a week for 3 to 4 hours on each of those days. Partial hospitalization is usually 5 or 6 day treatment where you kind of get there in the morning, you leave 6 or 7 in the evening so that you have nights and weekends free. And then there is also residential treatment, which is 24/7 treatment, just like inpatient would be, but it's not in a hospital setting. Residential treatment is often in, let's say, freestanding homes that have been remodeled for these purposes, sort of a more therapeutic environment, for lack of a better term there. But it really kind of varies depending on the symptomatology and the severity of those symptoms. So obviously, we would expect that people who have the most severe symptoms or who are the most ill are going to require those highest levels of care, like inpatient and residential. Whereas as you progress through your treatment journey, or if your symptoms never reach that level of intensity, hopefully we keep you on the outpatient side of things. And that's really the goal, I think, of treatment, is to have folks at a level of care that's the least restrictive to them in their daily lives, but also gets them to the important outcomes of recovery.
Great. Thank you, Christine. And thank you, Jeff, for your question. I wanted to ask a question that was pre-submitted by one of our audience members. Talking about brain donation, is brain donation helpful in understanding eating disorders? Does the neuropathology contribute to knowledge? And if so, what's being done to educate patients?
That is a great question. And to be honest, I don't know that I have an answer for that, other than to say broad brushstrokes. Brain donation is rare, but I think that what we're learning about the genetics of eating disorders and the neurochemistry that's involved in eating disorders, I have to imagine that if people out there are willing to donate their brains to science, specifically look at eating disorders, it couldn't hurt for us to have those sort of data to help us better understand how does, the eating disordered brain look differently than a non-eating disordered brain. We can get at some of that through fMRI studies and those sorts of things, but it's different than actually being able to look at the brain structures themselves to see, let's say somebody's been struggling with, an eating disorder for decades. Does their brain volume look different from people who have never struggled with an eating disorder? How do their frontal lobes maybe work differently from patients who have never struggled in those ways? It's a wonderful question, but one that, frankly, I don't know that I have a more succinct answer to, other than what I just sort of rambled out there here.
Yeah, that was great. That was, a very interesting topic that I'm going to look into as well. So we have a question in the chat. Is there any research to understand the potential long-term impacts of eating disorders?
Yes, there have been some really lovely longitudinal studies looking at the health consequences associated with eating disorders. Some of this is tough, though, because it's also complicated by the fact that some of these folks may have received treatment, and so their trajectory is going to look different from people who've never received treatment. But what we do know is that there are a group of folks that will have what the field is loosely terming, severe and enduring eating disorders. And these might be people who have been ill with an eating disorder for decades, and despite having been engaged in treatment at a number of different times in their lives, they're never able to achieve sort of full symptom remission or kind of get to a place of full recovery. We do think that there's some emerging data to suggest that these are folks that are qualitatively different from folks that may actually have a better chance at full recovery, not because they're doing anything wrong and that there's inherently something worse about their presentation. We just don't have a firm enough understanding to sort of figure out what sets them apart from somebody who is able to achieve full recovery. I think that when we think, though, about some of those long-term consequences, we see everything. Let me back up. It sort of has to do with every body system that is affected by the eating disorder. So long-term, if you're somebody who's struggling and not able to kind of achieve full recovery, we see everything from bone loss. We see things where, people are no longer able to become pregnant. We see, people who may be engaging in eating disorder behaviors so significantly that they end up losing dentition. We see people who may do permanent damage to their intestines or to their GI system, such that they have to have sections of their bowel resected, right? So it really kind of depends on severity of the illness, the trajectory of that illness, and the extent to which folks can actually engage in care. But again, these are really serious conditions just because of how significantly they can affect pretty much every organ system.
Thanks. And that kind of, I've had the thought of like eating disorders are, some people can compare them to addiction to drugs or alcohol, which just simplifying it, treating it is to avoid the substance, but with eating disorders, everyone has to eat, so it's kind of really managing eating and exercising in a healthy way. But as you were speaking about treatment, how would you describe I know you touched on some of this, but how would you describe the current state of the research on, like updated research on treatment? And has it have any new research showed like
Yeah, are there gaps, Christine, too? Are there research gaps?
Yeah, there are a ton of research gaps. That's the short answer. Unfortunately, if you look at the portfolio of funding in the NIMH, eating disorders make up a fraction of how much is invested in the study of these conditions. If you compare it to something like autism spectrum disorders, obsessive compulsive disorders, it's pennies on the dollar that are invested in studying these conditions, which is a real shame given that eating disorders have the second highest mortality rate of any psychiatric illness. Roughly 28 million Americans will have an eating disorder at some point in their lifetime, and one person will die from an eating disorder every 52 minutes. So we're talking about conditions that are common, they're life-threatening, and they're also incredibly costly. Deloitte actually put out a report in 2020 indicating that eating disorders cost the US economy roughly $64 billion in a single year. So those are year-over-year costs. And so when we think about the overall impact of these conditions, you'd think hopefully there'd be more research dollars invested in either investigating treatment, etiology, those sorts of things. It's not to say that there isn't any, but as somebody who's clearly biased, there just isn't enough. When it comes to, Jacqueline, your question about treatment, what I would say is that the persistent theme, unfortunately, with eating disorder treatment is that we have some really, really good ones, but they only work for about 50% of the people who receive them.
Wow.
And the vast majority of people that have eating disorders will never receive treatment. So we kind of have this dire situation where we have really common disorders that are life-threatening, but most people won't ever get treatment for them. And even if they do, our treatments only work for about 50% of the people that get them. So we have a lot of work to do when it comes to improving the treatment landscape. And I think that this is part of why I'm so hopeful about being able to focus on sort of early upstream pipeline initiatives that help us identify eating disorders early on so that somebody isn't waiting in their illness for 20 or 30 years to get treatment. Maybe if we catch these things earlier, maybe some of the treatments that we have will be a little bit more robust because we're catching folks early on in their symptom trajectory. But if there are other questions about treatment, I'm happy to take those. But I just think that the overarching theme really is that we have a lot of work to do when it comes to improving the treatment landscape.
Let me just interrupt, Jacqueline, with the question from the chat that's interesting. Christine, and I don't know the answer to this, is there legislation on the Hill around eating disorders?
There's a ton of legislation around the Hill on eating disorders, and I would be happy to talk about those if there are specific questions. But one of the pieces of my bio is serving as the current board president for the Eating Disorders Coalition for Research, Policy, and Action. We're an organization that is focused on federal policy aimed at making eating disorders a public health priority here in the United States. When we think about the pieces of legislation, what I would say is that a lot of what we're doing is not necessarily focused on eradicating eating disorders per se. I think that that's hard to think about on a policy level. Instead, what we're thinking about are how do we create an environment that is supportive of recovery? How do we make sure that federal appropriations are poured into eating disorders research? How do we make sure that we are helping to prevent eating disorders in people who might be vulnerable to them? So as case in point, one of those pieces of legislation many of you here may be familiar with is called the Kids Online Safety Act, or KOSA. It's Blackburn and Blumenthal. It just passed through the Senate a few weeks ago, and it's just passed House markup actually last week. And this bill is aimed at making sure that the social media landscape is one that does not intentionally harm children and adolescents who are at an increased risk for eating disorders. So, there's a ton of legislation that's out there that I think helps us create a safer environment for people who might be vulnerable for eating disorders, and that's part of the work of the EDC.
Wonderful. One thing I'll say is that we'll try to get these links. We're not going to have time to put all in the chat. We'll put them where the invitation to this Alliance discussion is on our website. It's called the events page. So please look there, and we'll put more links to resources. And so, Jacqueline,
So it looks like we are out of time, but this is
fortunately.
a fantastic conversation, so very eye-opening, and hopefully our audience, thanks for those who participated, and hopefully everyone has had to learn something new today. So thank you, Dr. Peat.
Great.
Yes. Before you go, please, I'd like to talk about our Alliance discussion next week. I just pasted the link in the chat. We'll have Dr. Jason Owen Smith. He's the co-founder and executive director of the Institute for Research on Innovation and Science, IRIS, which is housed at the University of Michigan. So we've asked Dr. Owen Smith to discuss this unique consortium and insights from its efforts to capture, communicate, and enhance the public value of academic research and higher education.
Speaking of importance to advocacy, they're really trying to get at the value of academic research and academic institutions through research. So it's very cool. So join us. It's going to be an interesting discussion.
And with that, thanks again for joining us this afternoon, and we look forward to seeing you again soon. Thank you, Dr. Peat.
Thanks so much.